Good afternoon, everybody. Thank you for coming. My name is Dr. Kahled Nour. I'm a gastroenterologist here at Memorial Hospital. I've been here in the community for several years, and I may have seen some of you, I'm not sure, but if not, then I would love to see all of you. Today's talk is, something that we try to always do, preferably once a year, but especially during the month of March, because this is the month of colon cancer awareness. But, we're always active in trying to inform the community about the importance of colon cancer screening to prevent and early detect colon cancer. What I want to do today is, have a discussion and keep an open forum. Just keep the floor open for any question. For anybody who wants to ask me a question, I'll be happy to answer it. At the very end, I will also ask questions, if anybody has questions, and I'll be happy to answer any questions you might have. What we try to do today is simplify our understanding of colon cancer and get the important discussion about how colon cancer develops, how do we intervene, how do we prevent it, and also how do we detect it if it happens early before it's too late to do anything about it. There are several points that I want to cover, and number one is what's the size of the problem? I mean, how relevant, how important, how big is colon cancer in our country? And how did that change over the past 30 years? Number two is what are the risk factors? Who's at risk? Who should be worried about checking the colon for colon cancer? And number three is what are the stages? How does colon cancer develop? We're going to go step by step from the beginning all the way until the late stages of colon cancer. So I'll show you how that develops. And that will give you an understanding of why do we intervene and when do we intervene. The fourth one is what kind of symptoms should we expect from colon cancer. And the fifth one is what kind of prevention do we have? What different methods that we have to prevent colon cancer. The last one is my advice, my recommendation, or my final word about that I want you to go away with, the ideas that I want you to always keep reminded of. So let's start with the first. So in terms of colon cancer, some important facts about colon cancer is that it's very prevalent above the age of 50. So it's kind of less frequent. That doesn't mean that it doesn't happen below the age 50, but it's much less frequent below the age of 50. But we start worrying about it above the age of 50, and that is changing, and I will tell you down the line why we think it's changing. According to the CDC, in 2015, Louisiana reported 25,000 cases of new cases of colon cancer in the whole state of Louisiana, and that's a lot. But it's pretty much comparable if you adjust for the population size between different states. Colon cancer is important. It is the second most common cause of cancer death in the United States.
What's the leading?
Leading is lung cancer.
Oh.
Yeah, in both, yeah, and it's the third commonest cause of cancer death in women. So in men it's the second, in women it's the third. It's preceded in women by breast and lung. So we have been always fighting to try to change that ranking, being the second. And over the past 30 years, we did manage to actually significantly decrease the prevalence and the incidence of colon cancer by trying to detect polyps early and removing them. And that's what we're going to talk about today by doing colonoscopies. We prevent colon cancer from developing by cutting off the way it develops by removing the polyps. We have actually decreased over the years the incidence significantly. We actually think that it's not the second anymore. So that's also because, we're very active every year in telling people, please come have a colonoscopy. Don't forget about colon cancer. Let's get your colon assured that there's nothing there that's about to develop into colon cancer. We are very unique when it comes to colon cancer compared to the other cancers. It's not the case with many other types of cancer. We don't have that luxury of being able to detect a stage that you can cut off, remove, and prevent it from developing into cancer down the line. In colon cancer, we do. We have managed to improve a lot on early detection by finding out maybe some genetic changes that we can do testing for different types of cancers. Breast cancer is one of them, where you would do genetic testing, and that would tell you that you are at a higher risk for developing breast cancer down the line. Then they immediately monitor the breasts very closely for any sign of developing breast cancer. But it's still not as good as doing colonoscopy, finding out the polyps, taking them out, and cutting off the chance of developing colon cancer. So colon cancer is very unique from this regard. What we can say is because we have been using colonoscopy a lot for the past 25 to 30 years, we have been discovering colon cancer so early that almost 9 out of 10 people who had colon cancer were found so early that they are still alive and healthy 5 years later, and maybe even until now. I can attest to this because I have a lot of patients that over the years I've discovered colon cancer in, and I've actually monitored them after we have taken care of the colon cancer because we discovered it early. We did the surgery, we took care of it. They came again and again for repeated colonoscopies, and years down the line, we are still not finding any evidence of recurrence of the colon cancer, and they have been cancer-free. So that type of cure is what we are targeting in colon cancer. We want to prevent it, but if it develops, we want to be early in detecting it and taking care of it so that it's cured and gone forever. So that's about the first issue, which is what is the size of the problem. The second issue is who is supposed to be checked. I don't want to discuss symptoms now, but the most important thing about who should be checked is that we should know that it is not related to a certain sex. Men and women both are affected, and they are both at risk. So it is not like, prostate cancer in men and breast cancer in women. This is for both sexes. And everybody should be screened at age 50. There is no predilection that would make one person not needing a screening compared to somebody else. So the rule is, if you hit 50, it's time to do the colonoscopy. No restrictions and no exceptions. But then we also know that some people are more at risk for developing cancers than somebody else. For example, if you have a family history of colon cancer, you're at a higher risk of developing cancer. And if that family member is a first-degree member, then the risk is even higher. If you have inflammatory bowel disease, and I don't know if you know that term, Crohn's disease and ulcerative colitis, these types of conditions where there's strong inflammation in the colon, there's a high tendency of developing colon cancer. So we monitor them very closely for cancer. So first-degree relative or any family member, any inflammatory bowel disease, and definitely if you are a person who tend to have a lot of polyps every time you have a colonoscopy, that usually increases the risk of developing colon cancer. But the rule, again, if you are 50 or above, regardless of the sex, you have to have a colonoscopy because you are at risk for colon cancer. Yes?
I had one every 5 years from 50 on until I got to 75.
Right.
They quit doing it. They said Medicare wouldn't pay for it past 75. So they quit doing
Okay.
colonoscopies. Is there a date? I'm 82 now. Is there
Yeah, actually, Medicare would pay for it. Medicare would not stop paying for it because you hit 75. I have my patients, and we go up to 80. This changed with time. We used to stop at 80, actually, not 75. But now we're having healthier and healthier 82, 83, 84, 85-year-olds. So we didn't stop at 80 anymore. I bring the patient, I assess them, I see if they're physically able to have the colonoscopy and the sedation, and I also ask them, are they willing to have it done or not? If they're willing and their health allows, we do it. But yes, as a general rule, I wouldn't stop at 75. I would probably, as a rule, stop at 80. And again, your health has to allow for it to happen, and Medicare does pay for that. It's something that if you want, we can always find out for more information and give you more information about as well. So that's the second question of who's at risk. We said everybody at age 50 and above. And just so that we make a comment about 50, we have noticed over the past many years that we are seeing more and more patients coming in younger than age 50 or at age 50, and they're coming in with colon cancer. And so the American Gastroenterology Association and the American Cancer Society, both of them got together and they decided that it's probably time that we start looking into the colon earlier than 50, 45 and above. So now the recommendation is at age 45 and above. Now the insurance this just came out, I would say, in the last year. So the insurances will probably take a little while before they start approving doing screening colonoscopies at age 45 and above. But we noticed the same thing. Me and my colleagues have been discussing that among ourselves even before the American Gastroenterology Association come up with that, because I would be scoping people at age 47, 48, and I find cancer. I was like, wait a minute, they didn't hit 50 yet, and they're not even due for the colonoscopy yet, and here we are, we're finding early cancers. And because this has been a pattern seen throughout the entire country, we decided to bring down the age to 45. So for future information, 45 and above is going to be the new 50 from now on. So the third point is, how does colon cancer develop? What are the stages? And I think this is important so that everybody gets to develop a mental idea of how does the cancer progress from one stage to the other. The one thing that I want to mention, I want to go all the way to one of the slides, is this slide. The cells in the lining of the colon are very quickly multiplying. They replace each other, old cells with new cells, every few weeks. As a matter of fact, we changed the entire lining of the colon within a few weeks with brand new lining that didn't exist a few weeks before. So this high rate of multiplication carries a risk of an error happening in one of the cells. While it's multiplying, an error happens. We have in our genetics a way to correct errors. But if an error doesn't get corrected, then the cells start piling on top of each other, and that's how a polyp forms, an initial error. There are billions of cells in the lining of the colon. So it's kind of understandable that the mechanism of multiplying over many years end up becoming a little ragged by you hit by the age 50. And then that's when error starts happening. One error, and then you get a polyp. And this is how a polyp looks like. That's a slightly bigger polyp, and this is a slightly smaller polyp. Again, all the cells are lining up next to each other. Oh, I don't know if you see, well, I guess, I don't know if you see the polyps, the cells are very difficult to see here exactly, but once an error happens, the cells don't respect the borders of each other, and you end up with piling of polyps on top of each other rather than being respectful of the neighbor margins between them. So that polyp multiplies just like the lining multiplies. And months pass, years pass, and the polyp grows in size, and then it gets a little bigger. And then when it gets beyond a certain size, and we don't know that exact size, the large number of cells of the polyp that are multiplying develop another error, and that's when cancer develops. So the initial error develops a polyp, the second error inside the polyp develops a cancer, and now we have what we call stage 0, a cancer developing within the polyp itself. So that grows and then starts going through the wall of the colon, and that's what we call stage 1. And then it gets to the surface of the colon, and we call it stage 2. And then it protrudes outside the wall of the colon and into the lymph nodes, and we call it stage 3. And then when it's big enough, stage 4, it spreads to other organs. It goes to the liver, to far away lymph nodes, and maybe even lung and other tissues, or the peritoneum. So we definitely don't want to discover colon cancer here. And once it gets beyond to other organs, it's not treatable as in cure. We want to get rid of it in a curative way. We want it all the way from 0 to 3, preferably even not 3, all the way to 2. But even if 3 is there, we can still get an appropriate cure. So the way to detect it is, number one, while it's still a polyp. No cancer has developed. One error happened, polyp developed, no second error, and we are not in a cancer stage. You take the polyp out with a colonoscopy, and it's gone. You have amputated the chance of it developing into colon cancer and stopped that progression. But if it develops, you want to catch it early. You want to catch it while it's in a polyp, and we had many patients where we took out the polyp, and then the pathologist looked at it under the microscope, and the report came back saying, well, there was a cancer in it. But the polyp is completely taken out, and we have removed all the tissue. So you don't do anything more than just removing the polyp, which would be an excellent scenario. The second best is to get it while it's still within the wall of the colon and remove it before it had a chance to grow and develop beyond the colon. And that's why it's very important to do colonoscopy. That's why it's very important to do what we call screening. We are screening to prevent this from developing or catch it if it developed very early. So what symptoms do you actually develop from colon cancer? First of all, there are no symptoms from polyps. Polyps don't bleed. They don't give you pain. They don't give you diarrhea. They don't give you anything. Polyps are asymptomatic. Yes?
What stage is that?
Well, this is a polyp that didn't develop any cancer in it. So it's just a polyp. So we talk about stages only if cancer developed. So if
you remove that?
Yeah. Yes, we remove it. We remove this one. As a matter of fact, we remove the bigger one. As you can see here, this is the snare. We use this instrument. This is a snare. We open it big enough to go around. So we open it big enough to go around and here, and then we guillotine it with cautery at the same time. So we just go underneath and we cut it. And then we suction it out through the scope, and we send it to the lab, and they look at it.
Yes, the instrument cuts it?
Yeah, the instrument that we pass through the scope. The scope is a long camera, and it has a channel. So we feed from where I'm standing. There's an opening. We feed the instrument through it. It goes through the channel all the way in and comes out next to the light and the camera at the end of the scope. And that's the instrument. So this is the instrument, the white one. And we open the instrument, so this comes out. This is a thread that's connected to cautery. We make it big enough to go around, and then we close it. Once we close it, we use the cautery, we cauterize the base of it and cut it.
And then it grabs it?
It's like a noose. You wrap around the base of it and then tighten it up. It just cuts it while cauterizing at the same time.
Okay. Now how can you tell when it's through the colon wall or not?
Well, this is a polyp. If it's much bigger and I'm suspecting if it is or it's not going through the wall, I usually inject underneath here. I try to inject all the way around some saline. I inject it with a needle, and that brings up the polyp, lifts it up. If it lifts up, then it didn't go through the wall. If it doesn't lift up, that means it's stuck somewhere deep in the wall, and you should not be removing it this way. You should send it to a surgeon. In this case, we mark it. We inject some ink, a tattoo we call it, an ink in the wall. And when the surgeon opens up the belly and he's trying to resect, he wants to know where exactly in the colon. He's got the whole colon. We mark it for them. He can see the ink that I injected. And he will say, oh, this is it. So that's the part that we're going to take out. So this is where colonoscopy helps a lot with surgery as well. So this is what we do. But what symptoms you get from polyps? None. But what symptoms you get from colon cancer? Also none. And that's what I keep emphasizing to my patients. You don't get symptoms from colon cancer until the late stages of colon cancer. When it's growing within the wall, it doesn't give you anything. It's not blocking the colon, so it's not going to give you any obstruction. You're not going to be throwing up and not able and distended and all of that. It's just growing. The colon is almost as big as this. So for it to grow here on this side, you still have enough space around it. And it won't give you pain. It's not big enough for you to give you pain. And most of the time, won't give you bleeding until too late. When it gets real big, that's when it gives you bleeding. So I tell my patients, the fact that you feel healthy, the fact that you don't have symptoms from your colon does not mean that you should not have a colonoscopy. Because most patients tell me, I've been talking to my primary care physician, he's been after me, telling me, you should go and have a colonoscopy, and I've been deferring it. I keep telling him, I don't have any symptoms, and I feel fine, so why should I have one? The answer is that you don't want to wait until you don't feel fine, because that's too late. By that time, there's not much that you can do about colon cancer, and there's not much that a colonoscopy can help with. Colonoscopy would help you when you actually feel good, because that's when you remove the polyp, prevent it from becoming cancer, and if it is cancer, you discover it early and be able to tackle it before symptoms develop. So these symptoms that I have here, and we'll go, I didn't want to put them so that you don't get under the impression that that's what you should expect from all colon cancers. The pain, the blood in the stools, the bleeding from below, from the rectum, the weight loss, and the change in bowel habits, and the fatigue, all of this comes from advanced cancer. So these are symptoms of advanced colon cancer, not just the usual colon cancer. Most of the colon cancers we discover it incidentally while we are just checking the colon, and then we discover either a polyp that has a cancer in it or an early tumor, and then we just take biopsies and find out that came back cancer. And we take care of it, and usually it's a good scenario because you want to discover it early, not late. So the next thing that we want to talk about is what are the methods that we have for screening? What can we do to screen? We talked about one, colonoscopy, which is what we recommend, and American Cancer Society and the American Gastroenterology Association, all of them recommend the colonoscopy high on the list. And way as a second and third and fourth are the other types of monitoring. Some of them you might be familiar with. So the cards with to check for stool, to put the stools on it and check if there's any blood in it. So these are either, we call it guaiac test or FOBT or FIT test. These are the cards your doctor, primary doctor probably will give you to go home and just apply some stool sample on it and then send it to the lab. The lab will look at it, changes color, and that usually indicates that there is evidence of blood in the stools. And usually do 3 cards because we want to see if it was one of them or 2 of them or all 3 of them came back positive for blood. The presence of blood in the stools can be because of many things. You could have hemorrhoids, and that and that can bleed, and will give you a positive blood test, a stool test. And it could be because of cancer, or it could be because you're taking aspirins or NSAIDs, or because you have an ulcer in your stomach, nothing to do with your colon, and it's bleeding a little bit, or because you're taking a blood thinner. There could be so many reasons why a positive test would be there. So this is why this is a weak test. The positivity does not usually indicate that it's necessarily colon cancer that's causing it. The same thing is the negative test doesn't help us very much, because even if you have a tumor, a cancer in the colon, it's not always continuously shedding blood. And so you could be doing the test at the time when when there is no bleeding from the tumor, and it will come back negative. And it's negative, but you still have a cancer in your colon. And you would feel very happy about the fact that it's negative, and you say, well, I don't need to do a colonoscopy then. There's no blood in the stools, and I'm fine. And that's a recipe for allowing the cancer to grow more and more and getting into later stages of cancer. So we in gastroenterology don't like the FOBTs. We don't like this test. And the American Gastroenterology Association usually puts that very low on the list. It's better than doing nothing. But sometimes doing something that comes back negative is worse because it gives you a false sense of assurance that everything is okay. That's why I want to mention this so that we all open our minds the fact that a negative test does not necessarily mean that everything is okay. And the same thing that happens also with Cologuard. We all heard about Cologuard, so it's commercially available. And so again, it has false positives and false negatives, meaning that it can be positive and not have colon cancer. And I see this a lot. I get patients who had the Cologuard and came back positive. We do the colonoscopy and we find a couple of polyps, or we'll find nothing, but we don't find colon cancer. And at the same time, it can be negative and not catch colon cancer while it actually exists. While Cologuard is better than this test, but it's still way not as good, not anywhere close to colonoscopy. There are other types like CT colonography. That's a CT scan of the abdomen. So it involves cleaning the colon and then having a CAT scan to take a look at the inside and the lining of the colon. So it's not always available in every place. CT have to be capabilities of the CAT scan in your neighborhood to do CT colon. Not every CAT scan machines can do CT colonography. And not every radiologist can read CT colonography. They have to have special training. And if there's stools inside the colon, it can be misunderstood as a polyp. And the opposite is true. A polyp can be misunderstood as a stools because sometimes it's difficult to tell, is this stools or is it a polyp? And the problem is that if they suspect you have a polyp on the CAT scan, guess what? You're going to have a colonoscopy. So why have a CAT scan and then end up with a colonoscopy when you can just have a colonoscopy from the start? A CT colonography is not cheap as well. So it's very important that when we pick something that we can rely on and can give us the answers. And if there's a suspicion of a tumor, you have to have a colonoscopy because we have to take a biopsy and find out if that's cancer or not. And if there's a polyp, of course, you cannot remove a polyp by a CT. The same thing with the barium enema. I don't know if anybody had barium enema before, but that's an X-ray test as well. The way they do it is that they inject through the rectum an enema, which is a contrast, that goes all the way up and fills the entire colon, and then they take regular X-rays. Now they have the X-ray in front of them, and they can see the silhouette and the outline of the colon, and they can see the wall, and they can see if there is any evidence of a polyp or a mass tumor in it. It would not recognize flat polyps, and flat polyps are just as serious in terms of developing. You've seen the sessile. These are the polyps that are protruding, but there is a different type of polyp that I didn't show here, which is flat. You can only see them, but not with a barium enema. And they can also confuse stools with polyps. They will say probable polyp. They are not sure whether this is stools or not. And again, if any finding was positive on a barium enema, if they suspect a polyp or a cancer, you will have a colonoscopy to get that taken care of. Remove the polyp or take a biopsy of the cancer. So again, why have two tests when you can have one? So the bottom line, we usually like to do colonoscopy. All the others are ancillary. We keep them in our back pocket in case a patient cannot have a colonoscopy. So we use them, but we use them as the second backup. If somebody is too sick, cannot undergo sedation for the procedure, then we do the barium enema or a CAT scan colonography. That's definitely better than doing nothing. And if somebody has a heart problem or on a blood thinner and cannot be off of the blood thinner, then that's also a candidate for this type of testing. So somebody might actually be at a certain age where he feels he doesn't want to have a colonoscopy. Then we can offer these in exchange of doing a colonoscopy. So there is a place for these types of other screening methods, but they are definitely not going to be our first choice. They will be our second choice. The colonoscopy, you're there, You can see the polyp. You can tell if it's a polyp or if it's not. You can clean and wash to be able to tell for sure. You can see flat polyps and protruding polyps. You can remove them. None of these other ways you can remove polyps. And if you see a tumor, you can take a biopsy of it to make sure that this is cancer. And you can mark it, like I said, with a tattoo for the surgeon to actually do it. So there's so many things that can be done that would help take care of the problem rather than just doing x-ray tests. So that's why colonoscopy became our standard. And that's the reason why we keep emphasizing the importance of doing it. The important thing, the important final thing, and this is my advice, is I want to kind of gather the information and remind everybody about the conclusions that I want you to take away. Number one is if you are 50 or above, and soon enough is going to be if you are 45 or above, make sure you talk to your primary doctor about having a colonoscopy. You cannot defer it because you don't have symptoms. You don't want to say to yourself, I'm fine, I'm doing well, I don't have any family history, nobody in my family had colon cancer, or I'm 70. Hey, I went that so far without having colon cancer, so I mean, I'll probably be okay. Actually, in reality, the risk for colon cancer increases with age. So if you didn't have colon cancer by the age 70, then you are at a much higher risk now of developing colon cancer than somebody else. Especially if you didn't have the polyps removed from your colon, then you want to make sure that none of these polyps is getting ready now to turn into cancer. So there is no age that we like to completely remove from the list of doing colonoscopy. At any age is possible. As I said, we go up to 80 as long as the person is healthy, and sometimes even beyond that if there is a very good reason for doing that or willingness on behalf of the patient to do this. Always ask yourself when you're having a test, is that really telling me the real information that I need or not? If you're doing a stool test and it's positive, don't rely on what I just said now. It could be just my hemorrhoids. Well, I said it could be hemorrhoids, but it can also be cancer. I don't want you to really try to find ways out of having a colonoscopy. I want you to actually try to convince yourself and your family and your friends that it is very essential that you get that colonoscopy done so that you are sure, not thinking that you're sure. You are definite and sure that everything is good with your colon. As I said, we monitor patients all the time, and we almost never had a patient coming in regularly for his procedures that ends up developing cancer. Compare that to somebody who never had a colonoscopy or was told to come back in 3 or 5 years and skipped, and it's 10 years. Now that's the one that I more likely find problems in their colon than the one that comes in regularly as told and gets the colonoscopy done and gets his colon checked. Do you have any questions? Yes, go ahead.
The small intestine.
The small intestine is above the colon. It's between the stomach and the colon. It's 4 or 5 feet long. We have been blessed by the fact that it has not developed have not developed cancer. The rate of developing small bowel cancer, it's not 0, but it is far much lower than it is in colon cancer, to the point that we have not at all needed to establish any screening protocol for small bowel cancer.
Have you developed anything to swallow before you take that test that's better than it used to be?
Okay, that's a good question. I guess everybody, so I don't know, I didn't touch upon how you prepare for the colonoscopy. But yes, there are. Well, now here's the important thing. There's always a big problem with volume and taste. 2 important things. And I'm separating them because one we have solved, which is the volume, but one we are still yet to solve, which is the taste. The volume that we usually use is the gallon, the 4-liter gallon. And I'll tell you, it's like an old car. They keep inventing new ones, but they are never as good as the old cars that they used to exist. They are always inferior. This is the Cadillac of all the preps, and that's the one that will definitely give you the right amount of cleaning. you want to always balance between your ability to take it and how clean the colon ends up, because you want to have a good test. You want me to be able to see well and remove polyps well. So I think there's a lot of patients who end up thinking about whether I'm able to swallow or finish drinking it, and not thinking about the other side of the equation, which is, am I going to be able to see well enough and clean enough for me to help him, tell him at the very end your colon is good and you're saved for 3, 4, 5 years. So the gallon gives us all the flushing that we usually need. The smaller preps that we developed over the years, and we have 4 or 5 of them now, they are more concentrated. It's easier for you to drink, but you have to make up the rest of the gallon by water, drinking water. And so I always emphasize patients, don't be dehydrated. Drink plenty of water, not soda, not juice, not Sprite, not lemonade. Drink water, because that's what's going to help hydrate your body. Otherwise, this concentrated small bottle that you've just taken is going to make you even more dehydrated, because it's very concentrated. So we have compromised on the volume. We improved on it. Some people can't drink 4 liters, so we made it 2 liters. We made it 1.5 liter, which is much better. But the taste is the issue that we are always trying to struggle with. So we tell them, chill it, put it in the fridge for a couple of hours before you start drinking, or for an hour and a half. Add a little lemonade to it, or use some of the Crystallite with different flavors, as long as it's not red colored. And that's usually many times the way, and drink with the straw. And I guess a lot of people don't know that. If you drink with the straw, you avoid the taste by a big factor. So most people usually just want to finish it all, which is okay, but drinking from a straw helps with the taste a lot. So chill it, add something to change the taste, and drink from a straw, and that usually helps improve things. If you take the concentrated one, please drink plenty of water. Yes, please.
I've had colonoscopies regularly for years. I'm now 75. I don't think I've ever taken the solution that I didn't throw up for hours and hours while I was trying to get it down.
Right.
I weigh 90 pounds.
Right.
I don't know. I'm scared to death to do I'm due for one in 4 more years, 79.
Okay.
I'm scared to death to do it because I get violently ill.
Right.
And I have, let me just say, and I have chronic kidney disease.
Okay.
So drinking the water is extremely difficult.
Yes.
I have never been able to drink anything.
Right. You mentioned something important here, is chronic kidney disease. If you have chronic kidney disease or if you have heart failure, you are not supposed to take the smaller ones. They're too concentrated. They will suck fluid out of your tissues, and they will deprive your kidney and injure your kidney. So they are contraindicated in somebody with congestive heart failure or chronic kidney disease. We have to do the gallon. Now, here's the important thing. Most people who end up doing a lot of vomiting and nausea are probably drinking it a bit too fast. And even though the instruction says drink that much every 20 minutes or something like this, we usually like that you slow down. So patients call me in the evening and they tell me I've been drinking and I've been throwing up. So I tell them take a break for an hour and then start drinking at a slower pace. Never mind what's written in the instructions about drinking it that much in that many minutes. Slower. If you feel that you're getting nauseous, stop half an hour, 1 hour, and then start again. It's your way of going around the problem rather than hitting it straight on. Being small, you might actually be able to drink 3/4 of it and be okay and get away with it. But that's something. Well, yeah, but you see, it's a matter of not the weight, it's a matter of the length of the colon. And for most of us, the length is pretty much equal. Unless you're a very tall person, then yes, you would have a much longer colon. In this case, you need the gallon. And I actually have patients that I have to do 2 days of prep because they require that much because they are that tall and very long colon. And if you're constipated, it makes it even worse. It means that you have to flush the colon. So my protocol, you take Miralax every day for a week leading up to the procedure. Even if you think you're regular, many people would be a little constipated and they don't know that they are. Take Miralax over the counter once a day. And then the day before, drink plenty of water, and drink plenty of water throughout the whole week as well. Especially in your case, because of your kidney, I would stay hydrated very well for a week before. And then drink the gallon slowly. Start early. Don't start at 6. Start at 4. Start at 3. And have an early procedure. So this way you drink as much as you can and slowly, and eventually go as often as you can to the bathroom. And once it's clear, early morning appointment, you get in, you have it done, and you go, before your colon gets again filled with bile and makes it even more cloudy again. So it's doable. You just have to work around it slowly. And hopefully you got it done. You still have 4 years to train. You can exercise.
Well, my question now is, since
Yes.
the last couple of ones that I had
Yes.
were with the smaller
Prep.
prep,
Yeah.
is that, and my kidney function has gone down, could
Yeah.
that have caused more damage
How,
to my
well,
kidney function?
I mean, it will cause damage immediately, not long term. So I can't tell you, I mean, if it did at that moment, at that point of time or not. So we definitely try to avoid these types of changes in fluids in somebody with chronic kidney disease. Yeah. And yes,
When you detect polyps when the colonoscopy,
Mm-hmm.
do you go back and do it, a removal, or do you do it while you're doing the colon?
while we are doing the procedure,
While you're
yes,
doing
yeah, while we're doing the procedure, we see them, we get the instruments out, we remove the polyps, and then we proceed.
Does rumbling or growling of the stomach indicate anything other than hunger?
Well, it can indicate a hyperactive colon. So if rumbling is the only symptom that you have, then yes, it's benign, there's nothing there. But if with rumbling you have an urge to run to the bathroom and have a bowel movement very soon after you have the rumbling, or if with rumbling you have cramps and pain and bloating with gas, then no, that is not just hunger. This is an irritable colon, and it's probably irritable bowel syndrome, IBS.
Thank you very much.
You're
Appreciate it.
Sure, my pleasure. Any other questions? Yes.
I want to give everybody else a chance.
Sure.
Would you please talk about the change in bowel habits? If you happen to go on today and suddenly you
Yeah.
can't and you're having distension, but then the distension comes and goes. Sometimes you get bloated and sometimes you don't.
Right.
Is that an indication that you need a colonoscopy?
Yes. We always, mark change in bowel habits as a significant sign, just like we mark rectal bleeding as a significant sign. So somebody who doesn't see blood and then suddenly starts getting blood, we cannot assume that this is hemorrhoids. We have to be sure. So we do a colonoscopy. Somebody was regular or had diarrhea, and then all of a sudden he's having constipation, or the opposite, there has to be, or regular became diarrhea, or regular became constipation, then a colonoscopy has to be done. Because yes, it is one of the signs and symptoms and signs of colon cancer. So now that doesn't mean that that's the only thing that can give you change in bowel habits. You can have change in bowel habits from irritable bowel syndrome as well, especially the distension that you get with that and gas. But we have to make sure. We're always suspicious until we prove that it's not colon cancer. But you need to be treated as well. So if you're having symptoms of change of bowel habits, let's find out what it is and let's correct it with medications if it's not cancer.
But you can't do a different kind of elimination test, like an endoscopy or whatever, before you get to the...
No, change of bowel habits, we have to check the colon. We cannot check anything else. Yeah. But you also emphasize another important part is that we usually like to, when we talk about repeat colonoscopy, your doctor tells you, okay, you had a screening colonoscopy today, you're going to come back in 3 years, or you're going to come back in 5 years, or 10 years. That doesn't mean that this is a guarantee that your colon is not going to have an infection or inflammation or something going on with it before that. So I tell my patients, unless you develop symptoms that requires that we take a look before. Remember, when you do screening, we are looking for polyps. You don't have symptoms. So it's like changing the oil on your car. You go change the oil, it tells you, well, 20,000 miles. You come back again for that. That doesn't mean that 5,000 miles down the line, you're going to hear some noise in your car, and you're going to say, what is this? I'm going to take it back again to the mechanic. So the same thing. If you develop symptoms for your colon, forget about when you're due. You're due 4 years from now. But if you have change of bowel habits, I would not wait until 4 years. It's now that you should get checked. Right? Right. Anybody? Yes, yes. Sure.
I'm curious.
No problem.
Do you go around?
All the way.
All the way?
Yes, we start at the rectum, and we go on with the camera and sigmoid on the left side, across the abdomen, and all the way down to the right lower quadrant here. We see the area where the opening of the appendix. We know we hit the beginning of the colon. And then once we reach here, we start looking very carefully, inch by inch, all the way across the colon while we are pulling, on the way out, we call it. And we examine the lining on the way out.
How long does that take?
Usually 20 minutes, 25 minutes in some difficult colons.
And what's the odds of you poking a hole in it?
That's a good question. Any procedure that you have, whether it's cutting your fingernails, or whether you're having a big surgery, or whether you're having a colonoscopy, always carries, or taking your teeth out for that matter, has some complication rate. The complication rate is standard across the entire country. It is usually reported as 1 in 1,000. 1 in 1,000 is 0.1%, and it includes things like bleeding or infection or reaction to the anesthesia medication, or even less likely, it's the least likely, is a perforation of the colon that needs surgery there immediately on the same day. So it is in the rank of 1 in 5 to 10,000. So it is very, yes.
If you had a complication for one colonoscopy, are you more likely to continue to have complications?
No.
If you had bleeding in one, is that likely to happen again?
No, usually, no. You have the same risk with every procedure. Now, if you had bleeding because you're taking a blood thinner, then yes, I mean, there is a risk. As long as you take a blood thinner, there's a risk that you're going to have some risk of bleeding. But no, the complications for perforation or infection or reaction to the anesthesia. Now, reaction to the anesthesia, it's important because that we have to find out what did you react to and avoid that type of medication when it comes to sedation. But if you have the same medication, yes, you're going to develop a reaction to the same medication, very likely. Yes.
If you're on blood thinners, did you get off of the blood thinners?
Yes,
A couple of weeks before you go in?
Yeah, not a couple of weeks. Usually every medication has a certain lifespan in your bloodstream, so we know when to stop it. So some medications 2 days, like Xarelto and Eliquis and so on, and some are 5 days, like Plavix, for example. We don't recommend stopping aspirin anymore. We don't think that it increases your risk of bleeding at all.
Is a baby aspirin?
It's fine. Yeah, baby aspirin is fine. It doesn't increase your risk of bleeding. So I keep my patients on aspirin. Yeah. Yes?
To schedule the procedure, is that done through our primary physician?
You could be directly, you can contact us directly if you want.
Is
So,
that an overnight stay in the hospital? Is that admitted
Yeah.
to the hospital?
no, this is an outpatient procedure. So we tell our patients, make sure that you come with someone to drive you on the day of the procedure. Anesthesia talks to them. We start an IV, we give them medication, put them to sleep. We take a look, 15, 20 minutes, like I mentioned. We remove the polyps, and then we take them to recovery. They wake up, and then I come and talk to them and tell them the results. And then we have them go home with whoever is driving them. They stay at home and rest and recover, and we tell them that day, don't drive, don't make decisions, and then the next morning they're back to normal driving and working. So usually those who work, they only take that day off from work, but they're back to work the next morning.
Do you still use Versed?
No, those days are gone. So yeah, Versed and fentanyl used to give a patient a twilight sensation. He's out, but he's not out. Sometimes they would be usually there's forgetful of anything that happens, but they are not as asleep and as comfortable as propofol does. So that's what we use, propofol. And propofol is an excellent medication because, and the anesthesia usually gives it, because it induces sleep very quickly. The moment we give it, you're out. You won't have a chance to count up to 5, and you're out. And you're going to continue being out throughout the procedure. He will continuously give it to you. If you notice you started to move, he gives you a little bit more. So it's very smooth. You don't wake up in the middle. And then the moment I finish, he stops giving the medication, and 2 minutes after that, you're awake. While I'm typing the notes on the computer, the patient is on the bed behind me, and he is talking to me. And we take them back to the room and in recovery, and by the time they hit the recovery area, they are fully awake. They can talk to their husband or spouse or something like that. And when I come to them after the procedure and talk to them, they remember everything. That was a problem with Versed. You give Versed, I come and talk to them, they go home. And then they call and say, doctor, you didn't talk to me after the procedure. And I tell him I did, and your wife was next to you, and then his wife says, yeah, he talked to you. What are you talking about? They forget that even though he was awake when I talked to him, they don't register what we tell him. And this is important because I want to tell him what we found and what the instructions are, what I want him to do, if I want him to take a certain medication or I want him to follow up or do a test. I explain that to him, and I want him to remember that. So propofol helps us a lot from that point. Everybody remembers everything. And everybody wants to take some propofol home. Everybody loves it. They tell me, can I have some of this medication home? Because it was fantastic. They have the best sleep ever. It's fantastic. It's surprising how many people tell me the same sentence. This is the best sleep I ever had. Can I take some home? So you'll like propofol, I assure you.